In this session, we will be joined by representatives from Gatekeeper in 3 different European regions, and they will share stories of how they have successfully implemented innovative solutions and the positive impact that they have generated. We'll have a space, of course, for debate on the measures and strategies to transform healthcare systems and the challenges and barriers they face in effective integration. To lead this panel, we are honored to welcome Mr. Francisco de Paula Rodriguez, Health System Strategy Director at Medtronic Ibérica, who will manage amazingly this conversation after shedding light on how the industry can support the implementation of innovative solutions. Mr. Francisco, the floor is yours. Welcome.
So here we are. Good morning, everybody. My name is, in the shorter way, Paco. I work for Medtronic, and I represent this company, world leader in healthcare technology, and at the forefront of innovation. Our involvement in projects like Gatekeeper is rooted in our belief that innovation is a responsibility we have to improve lives. Through our open innovation model, we collaborate within healthcare ecosystems, leveraging our internal R&D capabilities with that of external partners for addressing the real needs of healthcare sector with innovation that truly make a difference in people's life. The roundtable I will moderate, that will begin immediately, is about healthcare regional strategies for implementing pioneering innovative solutions. We will have presentations from pilot projects coming from 3 European regions, as has been said before, in Puglia, Italy, in Aragon, Spain, and in the Basque Country in Spain as well. It's a pleasure to introduce to you the panelists that will join us in this roundtable. Mr. Franco Mercalli, Multipede Engineer Partner and Puglia Pilot Operations Coordinator in Italy. We should have, in online connection, Mr. Giovanni Gorgoni, CEO of ARESS Puglia, the regional government agency for a Puglia region for innovation in health and social care. It's also with us Mrs. Maite Hurtado, coming from Aragon, from the Innovation Unit at the Aragonese Health Service. Is joining, coming from the Basque Country, 2 people, Mr. John Eneko Idoyaga, methodologist, European project coordinator at Bio-Vizcaya Research Institute, with a strong background in pharmacy and coordination of multi-stakeholder projects. And together with him, Mrs. Irati R. Urenea, researcher and project manager at Biosystemac Institute for Health System Research at the Basque Country. She has a background in journalism and a postgraduate degree in health promotion and community health. So, we have all the introductions done. We will see now the presentations of each of the regions. It's important to remember we have 5 minutes with some flexibility for each presentation, and then we will go into a debate we have already prepared. So let's begin. The floor goes to Mr. Franco Mercalli.
Thank you, Paco. Okay, I will skim through 2 experiments that we conducted in the Gatekeeper Puglia pilot. The third one can be seen at the booth down there. And one is regarding any coaching support for health promotion, and second one, AI modeling for healthcare, predicting healthcare expenditure. The e-coaching service consisted of streams of messages sent to the smartphone of the participant through multiple channels, like, for instance, the Gatekeeper Samsung app, or SMS, or email, and vehiculated healthcare promotion resources, which were selected and validated by partner CSS, which is the clinical partner in the Puglia pilot team. The resources consisted in videos or PDF documents or a link or web pages, something that could be transformed into links to be proposed in the message themselves. I skip this to be faster. I go directly to the satisfaction questionnaire that we proposed to participants after the experiment, and they show high appreciation for the service. But it is important to note that elderly participants, those aged 75 years or more, were even enthusiastic about the service, confirming that this paradigm is very well suited for this segmentation, for this population segment. And OK, I will skip this again to be faster. Another important aspect of this experiment was that we administrated not only satisfaction questionnaires, but also the EQ5D questionnaire, which is a standard instrument for measuring quality of life. And we administered this before and after the experiment. As you can see in the upper left corner, we were able to observe an improvement in the perception of quality of life in participants. This also allowed us to use the MA5 tool recommended by the Gatekeeper platform to assess the incremental cost-effectiveness ratio. For instance, if we hypothesize a 50 euro per year fee to deliver the service, this would correspond to 2,000 euro per quality-adjusted life year gained, which is a very good value. The conclusion for this experiment is that Gatekeeper allowed us to set up and deploy an e-coaching service that was appreciated by users, able to improve their quality of life perception, and be cost-effective. I skip the future plans to save time and go to the other experiment, in which we started from a retrospective data set available at ARES regarding more than 3,000 chronic patient cases, including features on demographics, healthcare provision, and healthcare expenditure. We translated this data set into several tens of thousands of FHIR resources, according to the Gatekeeper FHIR implementation guide, and stored this into the Gatekeeper Data Federation. From that, thanks to this, we were able to leverage the AI framework of the project and the related HPE Esmeralda platform to conduct several AI model training experiments. We wanted, in particular, to compare deep learning with conventional learning schemes, like, for instance, linear regression or XGBoost. I go directly to the results. You can see here one run of the 20 times 10-fold cross-validation experiment that we conducted. And on the right, you see the results. The conventional linear regression was not even sufficiently stable to have a comparison, while ridge-corrected linear regression and XBG regression were. So we have statistical significance in the comparison. And in both cases, deep learning revealed to have a superior performance, confirming our research questions. So the conclusion here is that thanks to Gatekeeper, we were able also to leverage retrospective existing data set, convert them into standard FHIR, and leverage the platform, the Gatekeeper AI tools, in order to derive insightful conclusions that, in this particular case, could improve in future decision-making on healthcare resource optimization. I guess this is all, and I leave the floor.
I thank you so much, Mr. Franco Mercalli. We don't have the connection with your colleague, so we will have to move forward. We will keep trying to restore it afterwards, but let's move forward.
Okay.
Mrs. Maite Hurtado, the floor is yours.
Okay, hi to everyone. Okay, it's a pleasure to be here. I don't know where my slides are, because I think that they have to move them forward, because we're current number slides. Okay, but while we get there, okay, here they are. Okay, I will give a brief introduction as to who I represent. I represent the Servicio Aragonés de Salud, okay, which is a public institution under the health department in Aragon, and that's the one that provides the health care for primary, specialized, and mental health. I have to say that within they provide the healthcare, but the health department is the one that sets forth the strategy. They work very closely together, okay, in overcoming all the obstacles and in setting forth all the digital transformation that is being taking place nowadays in Aragon and in the future. I have to say that the setting of Aragon, I know for those of you who are not aware where it is, it's a region, it's a very large region in the northeastern part of Spain, but we are very sparsely populated. We only have 1,300,000 people, of which 200,000 people are over 65, and of which of those 70% have chronic illnesses. This means that we are increasing in elderly people and in chronicity, and therefore the importance of gatekeeper and the importance of AA tools. All the 4 RUCs that we have done 4 RUCs, one in low intervention, 2 in mid-intervention, and 1 in high intervention, are all encompassed under the Aragon Digital Health Strategy, which aims to transform digitally all the healthcare services so that we can reach the paradigm of a value-based medicine, always based on data. We believe that AI and data is of importance for the future. And it is so that we have already in the process of purchasing business intelligence tool, and that we will be setting out ETLs to be able to see how we can capture all the necessary data to be able to make all the best decision making for the future. So, okay. Since we had 4 RUCs and I had a lot of slides, I've decided to concentrate just on one of them, and for one particular reason, which will be my final conclusion. I have to say that I will concentrate on the mid-intervention telemonitoring, okay, which is really a platform that is used to provide integrated care to complex chronic patients, okay. We provide integrated care taking into account very personalized care plans, the health requirements, the clinical requirements of the patient, and also the social requirements of the patient. And this, we've done it via a collaborative platform, an IC tool, okay, which is able to gather all the vital signs to help us make decisions. We have also made a big emphasis in inclusion of predictive models for early diagnosis and for decision making. Many users have been involved. In fact, in our pilot site, we had over 100 professionals, but in concrete, more precisely, in this one, we've had 59 healthcare professionals involved. We've had over 200 patients, 28 caregivers. We've had 4 social associations like the Alzheimer, the Aragon Institute of Social Services, and also the ones from the Comarca Somontano. Like I say, patients over 65 suffering from 1 or more chronic diseases, polymedicated, okay, and that needed both clinical and social attention, okay. Just to give you some figures, okay, I know there's many graphs, but I would just pinpoint, okay, that most of them, we had an intervention group and a control group, and in both we found that hypertension is the most prevalent disease, followed closely by polymedication and heart failure, okay? If we go to the Barber scale, we will also see that from the 165 patients, participants that answered the questionnaires at baseline and endline, we have seen, okay, that the percentage in the baseline was slightly higher to that of the endline. If we look at more results, and we also did the Barber index, okay, we will see that precisely 56%, 35% at baseline were independent, whereas using the tools, we found that this increased, okay, to 40% at endline. According to the quality of life, we have seen that we've achieved a mid-high score, okay? They all consider they have a moderately good well-being, okay? And the patient activation measure has shown that they are all very conscious. We've actually, one of the things we have achieved is that people have become conscious of the chronicity and how they have to deal with this, and that they also have to be participant of taking care of themselves. And with the regards to the caregiver burden interview, we interviewed the social entities we brought on board, and we discovered the Alzheimer Association was the one that perhaps had a higher burden, but this is because of the type of patients that they are dealing with. They all have cognitive problems, and this is why. And with the usability scale system, the SUS, we have discovered that, well, that this is true, that we couldn't really measure it so much with the patients, but it was because most of them have family members or carers that look after them, and of course, these people are computer literate, and they are able to use the system well. And another conclusion, I think is probably one of the important, is that we found that in the intervention group, nearly 5 times more contacts, they had nearly 5 times more contacts with primary and specialized care than in the control group, for example, and that both groups we have equally in proportion to the nature of contacts, planned and unplanned in all categories. Conclusions, and I think probably this is the most useful part, is that this has been rolled out in a rural area, and this is shown to be extremely useful in a rural area. This means that we have made these services accessible to all users. And this is one of the main aims within the digital transformation strategy, is that we have to make accessible all services to everyone. Also, within the clinical activity, we have found that there's been a frequentation shift from specialized care to primary care and from emergencies to program activity. And also, in the case of the healthcare systems, there's been a shift to be more reactive than to be more proactive. And this is great, and this is thanks in part not only to the actual piloting of the telemonitoring system, but also to all the data that we have, and we've been able to process and be able to shift and be more reactive than proactive, okay? More from reactive to proactive. And just to mention that what started, we were mentioning it before because I'm over here with 3 colleagues that they've been working with for the last 15 years in all these projects, that in the last 15 years we've worked so hard that now it's a consolidated service, it's part of our strategy, and we have been chosen together with another region, Galicia, to lead by the Spanish Ministry of Health, to lead the telemonitoring project and make its implementation and rollout for the whole of Spain, for all the regions of Spain. So that is perhaps, and this is thanks to Gatekeeper, which was the last obstacle that we had to overcome, that we have reached this. And then just some lessons learned. Just as a thing, I think this is true for all the pilots. Co-designing is crucial. All stakeholders have to be involved from the onset, professionals, carers, patients, everyone. Everybody has to be involved. We need to enroll professionals and decision makers and organizations at the definition phase. This is very important. We need to train participants. We need to comply with data protection legislation. We also need to help in the organization of frequentation, which we have seen that we are getting there, but there's still a lot of work to do, there's still room. New services take time and effort. It's taken us 15 years. I mean, it takes time and effort, okay? We have to do it in a systematic building block approach. We cannot just go out and say we're going to do this big pilot. No, we have to do it little by little, okay? And trying out different service models. Questionnaires are important. We need feedback. We need to know where we have to do as a continuous improvement to the system and to the services. Change management. I was talking to my colleague from Cyprus. Change management is an issue. It takes a long time, and it takes a lot of effort to change people's mindset within the organization. And that new services should always be part of the strategies of the health department, and there should be roadmaps in place. So that's all from my side. Thank you.
Thank you so much. Mrs. Maite Hurtado. It's the turn now of the Basque Country, beginning with with both.
Yeah. Hi, good morning to all of you. And before starting, I would like to thank to the coordination team just to give the chance to the Basque Country pilot site to be here in this great event, and also to present some of the work that we have done in our region. We are Joneneko Idogoya, and Irati Regerena. We belong to 2 research institutes, BioVizcaya and Biosistemac. This is a good opportunity today to present the new names of our research institutes. Till today, until September, we have been Biocruces Vizcaya and Cronigune, but we have changed and we have become BioVizcaya and Biosistemac. Our organizations are part of the Directorate of Health Research and Innovation of the Ministry of Health of the Basque government that defines and implements strategies and action plans to health research. So our organization acts as a catalyst for change and a digital transformation of our health system. We gather all the transition research. We are aligned with scientific areas through different research groups. We support and we work closely with our healthcare system, in this case Osakidetza, that I would like to say that it has been also part and partner of this Gatekeeper project. And we develop and implement scientific technological service platforms. So in Gatekeeper, we have been pilot site. We have implemented 5 use cases to tackle or to approach different topics or different challenges, like diabetes, Parkinson, stroke prevention, health promotion, and polypharmacy management. We have had a very close collaboration with Osakidetza Health System and as well different community setting organizations. Here there are some figures of what we have enrolled and what we have achieved. We have had more than 800 patients involved in our use cases. We have approached and we have reached more or less 9,000 citizens. And there is another figure that I would like to highlight is the participation of the healthcare professionals and as well community setting professionals, with more than 500 professionals involved in our use cases. And now we are going to share 2 use cases, 2 interventions that we have deployed in our system. One in church by Biosistemac, to manage the polypharmacy. So the objective of our intervention was to assess the effectiveness and user experience of 2 technologies. One, target to healthcare professionals, check the meds, to optimize pharmacological treatment, and another one, a mobile application, My Treatment app, that it's available to all citizens and is cooperative in Osakidetza, to improve the adherence. So here you have some pilot data. This intervention has been deployed in at least 11 integrated healthcare organizations. I would like to point out here that our system, Osakidetza, is structured in 13. So we can say that all the system has been involved in this intervention. We have had 285 healthcare professionals participating in this intervention, and we have enrolled more or less 700 patients. When it comes to the assessment evaluation, we have gathered different data through some validated questionnaires to assess the health quality or to see the treatment adherence, then also to evaluate the usability of these 2 technologies. And finally, we have extract and get data from the electronic health record. When it comes to the relation to the deployment in the Gatekeeper platform, I would like to say that these 2 technologies has been integrated in the healthcare system, in this case Osakidetza. But the idea was to send data to data federation. So we developed different connectors, and through these connectors, the data from Osakidetza and our intervention has been sent to Gatekeeper platform. Some preliminary results of this intervention with the data that we have extracted from Osakidetza database. We have had very old patients involved in this intervention, more or less 78 years old, and most of them, a high percentage was male. It is something here to highlight and that we've got a very significant figure that we have get the decrease of drugs prescribed. At the beginning, these patients had an average of 13.6 medicines prescribed, and once in the follow-up, once the intervention has finished, we have seen that these drugs prescription has been decreased in 2 drugs, more or less. So it is a good figure. And then we can see that we have improved as well the compliance. They were patients that were compliant, but we have this figure has been better when it has been finalized. So as a conclusion, we can see that we can set that innovative solutions can boost this improvement of appropriate polypharmacy together with the adherence of a prescribed medication. And we can see that it can be also improve the efficiency of the use of healthcare resources. So now I give the floor to my colleague, Jon Eneko, to present his use case.
Thank you very much. So now, well, my name is Jon Eneko. I work in Vizcaya, and I will present one of our use cases that has been successful here in Vizcaya. This is the use case 6, which is about the stroke identification, whose objective is to evaluate virtual reality as an educational tool in the identification of a stroke code. This study was deployed entirely in the Cruces University Hospital and involved subjects who were older than 50 years old. There were 52 patients involved in this study who were either survivors of a first stroke or with high risk of suffering a stroke. The study was conducted the following way. First, some tests and questionnaires were performed. Then the virtual reality training was performed in the patients, displaying videos who showed the early signs and symptoms of a stroke. And after this evaluation of the virtual reality training, we had also the same test performed to see the differences between baseline and the final results. The questionnaires performed were the stroke knowledge test, the objective structure clinical examination, which is an examination that we have developed and created in Vizcaya. Also the TOFLA questionnaire, the adherence to Mediterranean diet questionnaire, and other quality of life questionnaires. This study was developed together with Tecnalia, which is another research and development institution in the Basque Country. They help us creating these videos, these virtual reality videos, which showed all the situations that may identify a stroke. So the piloting preliminary results were carried this way. The evaluation was done before and after watching the virtual reality videos. In these videos, the scenes about an early signs and symptoms of a stroke were displayed. And well, the data that we gathered were that patients involved in the study were more or less 62 years old, an average age. There were more or less 60% of stroke survivors, and most of them were female, almost 55% of the subjects. As we can see in the results that we are displaying here in the presentation, the results of both the objective structured clinical examination and the stroke knowledge test were better after watching the virtual reality videos than before, because we got statistically significant differences. So our preliminary results, we can say that show that the immersion in virtual reality videos improved the knowledge of participants and helped them in the identification of the early signs and symptoms of a stroke, which encourages us to keep going with this study further beyond the Gatekeeper project and to recruit more patients to further train this tool. And this is all from my side. Thank you very much.
Thanks to you. So we have now, I've lost the time, almost, I think, 20 minutes to have the discussion. Unfortunately, one of the participants in the discussion is not available through Teams. We lost connection. We will move forward with our two participants from Aragon and from the Basque Country. And this is my first question. In light of the project success stories we've heard, what measures do you believe regional health services should prioritize to effectively adopt and scale innovative AI technologies? Maite.
Okay. Thanks to all the experience, this 15 years of experience and the gatekeeper and the results that have been yielded from the actual use cases, we say that we need to focus more on solutions that support diagnosis. This is important. We need to find solutions that can help and facilitate communications between all professionals. That means all the care levels, yes. We need solutions that can bring together the patient closer wherever they live. In other words, we need to bring the services to the patient. We don't need the patient to travel to the services. We need to have a system that can effectively measure the results of these new services and the way we are implementing them so that we can do a continuous improvement of them. And we need to know how we can effectively do data exploitation. And this means effectively. In other words, there are many solutions out there, there are many technologies, but we are discovering that in some cases, they are giving false positives. So we have to really be very careful that it's not a question of just putting in a tool, it's a question of knowing what data we need, where it is, how we can access it, how we can correlate it, and how we can use it to give us the correct answer that we need to make a good decision.
Very interesting. Thank you. What about you? What do you think?
From our side, I would like to highlight just two issues. From one side, it is important for a project success and real implementation in healthcare settings to bear in mind and know which are the priorities of the health system and which are the needs that are to be answered, should be answered through these AI technologies. So if we know which are the priorities, it would be easier to select or develop the specific AI technologies and then test it in order to see if these technologies answer to the real needs of this health system. And then there is another issue that's important, is to have a well-defined and structured procedures for the real implementation in the health system. This is important. So in this line, it has to be remarked that always take into account these priorities that the policymakers has identified, and in another way, having also taken into account which are the needs that the front-end professionals has identified. So I can say that it's it becomes like a dual approach, like a bottom-up and top-down. So both things should be taken into account for this.
Thank you so much. Back to you, Maite. Discussing the sessions team, could you share specific initiatives or policies your region is implementing to digitally transform healthcare services, particularly in the context of chronic disease management?
Yes, so we have, as I mentioned before, we do have a digital health strategy already defined. It was defined back in 2021, and it goes up to 2026. It's in continuous evolvement, okay? It has several strategic lines on which we are basing all our digital transformation, which are liquid health centers, and let me explain, which is really the aim to provide accessibility of all the services that include teleassistance, telehealth, telemonitoring, integrated care to anyone within the region, wherever they live, okay? And also to help the professionals, okay, be able to provide this care. It's also based on personalized medicine that aims to improve the diagnostic ability. We have to recall that in our region, we are a very big region, sparsely populated, high levels of aging population, We have also a program on chronicity, on elderly people, on active lifestyles. We have many, many other strategies that fall under this digital health strategy, which are in continuous evolvement. And then we have another strategy, which is the smart health, which is really going towards a unique, intelligent healthcare record to support in decision-making. At this moment, we are undergoing very important infrastructure, digital transformation, where we are integrating all the systems. As I mentioned before, it's essential to know what we have, where we have, what normalized data we have to make the correct decision.
Thank you.
In our case, hi? Yeah. In our case, in the Basque Country region, the Basque government, through Osakidetza, the healthcare system, we have the digitalization strategy, the e-health strategy, that the idea is to encourage and promote this integrated care and digital transformation of the system to deal with the aging, dependency, chronicity, and so on. So the aim of this e-health strategy is to guarantee the finance sustainability, is to guarantee the accessibility of all citizens to the health data and health information, also to contribute to the reduction of the different inequalities in the community and in the system, and also to improve the quality of health and care. So in the system, we've got, I can share with you some tools that we are available and are available to professionals or citizens. We've got the electronic health record. It's a well-structured platform that encourages this collaboration among different healthcare services, primary care, hospitals, as well as residents. Then we've got the e-prescription platform that it's available in healthcare centers, hospitals, and also connect to community pharmacies. And finally, for example, we've got the personal health folder. It is a platform that the citizens can access to their different reports, clinical information, and so on. All these tools, and there are more tools that are integrated in this in our system, but all these tools are part as well of the digital transformation of the Basque Country 2025 strategy. So this strategy aims to promote the digital transformation in all environments in the Basque Country, and also encourage this collaboration among different stakeholders. And then something that I would like to highlight, and that they are now focused on working on, is that the system is immersed developing the regional health data access body. I have read that. But it is something that we have been working here in Gatekeeper, and it's important, is the use of the secondary data, because we need data. There has been another sessions that they have said that the importance of having data to develop different tools, AI services, and so on, but this should be structured and should be in a correct process. So the Basque Country wants to give this data for research, for different developments, so we are immersed on that. And I think that it's important that we are aligned with the priorities of the European Union, Commission, and so on.
Thank you. Time is over. Oh. So we don't have time for the third question we had ready, but anyway, thank you so much. Franco Mercalli, Maite Hurtado, Ion Eneco, and Irati Egrewene. Thank you so much.
Thank you.